Good morning, everyone, and welcome to our seminar focusing on digital health and LMICs. My name is Dr. Manish Kohli. I'm a primary care physician who has been part of some digital transformation initiatives initially. I'm a member of GCEA. I'm also the co-founder of Pull Alliance for Digital Health and Equity. Joining me is Tom Judd. Tom, please introduce yourself.
Good morning, everybody. Clinical engineer, actually a co-founder of Pull Alliance, and you'll see why after a while, and currently GCEA, the Global Clinical Engineering Alliance Liaison Director, and formerly a board chair of IFMB CED. And of course, we have the current board chair on the panel today, Fabiola Martinez. And I did spend 25 years with Kaiser Permanente, and that will come up during our presentation. Manish?
Thank you. Next slide, please. So our focus today is really to talk about four main topics. One is talking about the fragmented nature of resources and the pressing needs that LMICs have. And we believe that digital health tools can help strengthen the health systems and meet the needs in the future. GCEA and Pull Alliance have signed an important partnership for impact, aligning resources, people, processes, and technology. Let me remind you, digital transformation is not about technology. It's about people first. And how do we actually engineer a better healthcare system that leverages technology to improve access to care? Collaboration is the key word here. Together, we can go far. And we have to innovate. Innovation is not a piece of technology, or not only a piece of technology. Innovation is how we work. Every industry has undergone that. And then we really want to highlight that this work cannot be done by doctors and nurses alone. We need the team of healthcare professionals that includes clinical engineers who understand technology, who understand healthcare processes, who understand patient outcomes, to be partners with nurses and physicians and everybody else in the healthcare enterprise to drive transformation. And then we have a call for action for all of us. But before we get started, we have a quiz for everyone. Callie, could you please share the quiz with everybody? We'll give you about 30 seconds to go through 4 questions. And question 2, we are not expecting 200 characters, perhaps 20.
I believe the attendees can vote and not the panelists, but that's good. Do you have the necessary knowledge and skills to undertake digital transformation? What's your biggest barrier? Available training? And familiar with AI? As you answer those, thank you.
So we live in a very interesting world. In a world where more people have access to a mobile phone than they do to a clean water, electricity, or a toothbrush. And when we see the data on growth in GDP, the second table in the slide, and the growth of mobile phone subscriptions is pretty striking. Most of the countries have adequate to good penetration of mobile phones, which means even people in countries like Burundi, which have a GDP of $708, can boast a penetration rate of 58 mobile phones per 100 people. Still room for growth, but now we have an opportunity to reach people in some of the most vulnerable communities and countries and engage them in their own healthcare. Next slide, please.
We're showing the results of the poll, I believe. So just give the panelists a moment to see that. Knowledge and skills about 50%. Biggest barrier, available training. There is good preponderance of, well, yes, and or minimal, and some response about AI.
We may need to scroll down. I don't think it's visible on the screen.
Yeah. I think we need to proceed, though.
Thank you. The world we live in, with the increased mobile penetration and access to the internet, we're generating a lot of data. Data is pervasive and ironically is underutilized for informed decision making. And it could not be more important in healthcare. Next slide, please. Not only do we have big boxes, we have a proliferation of little boxes. We have increased consumption of digital technologies. Consumerism has entered healthcare. People are becoming more mobile, and they expect healthcare to reach where they are. COVID has given us the gift of telehealth, where it's acceptable for one to consume healthcare at a distance. We have a preponderance of wearables and genomics, which drives precision medicine. All of these technologies are sources of data that come within healthcare space. So when we look at healthcare as an industry, it has the highest annual compounded annual growth rate for data, 36%. And we are perhaps one of the least efficient in utilizing that data to impact medical decision making. We need to change that and fix that. So digitization is not about implementing a technology. It's actually about maximizing the value of that technology and the data it produces to create informed decision making for each and every patient encounter. We believe access to not just healthcare, but access to safe, quality healthcare is a human right. And when we look at the current data, and this is despite all the implementation of technology in healthcare that's taken place in the last 20 years, we still have a lot of work to improve safe care globally. 1 in 10 admissions, according to WHO, leads to an adverse event. And 1 in 300 leads to death. This is unacceptable. More than 43 million people are injured worldwide due to unsafe medical care. In India, according to one study, 5.2 million deaths annually occur due to medical errors. So we have to put our heads together, our teams together, our technologies in an integrated manner that help us solve for this problem. And next slide, please. And the workforce shortages. Some of them are absolute, some of them are relative. But collectively, what they contribute to is the lack of access to care. Globally, there's an estimated shortage of 18 million healthcare professionals. Of that, 13 million nurses will be needed to fulfill the gap that exists. We also have a situation of increasing burnout where we're losing medical professionals earlier in their careers. And 89% of nursing shortages are located in the LMIC. And we have 76 countries around the world that have less than 1 physician per 1,000. Now, one solution is let's train more doctors and nurses and let's get every specialty in every community. While that's an applaudable goal, that is not a realistic one. What we have to first begin to focus on, how do we maximize the efficiency and the utility of every healthcare professional? What we like to fondly say, Tom and I were speaking the other day, how can we get everybody to work at the top of their license and expand their skill set to do more? And this is where we talk about CEs taking a more active role in digital transformation in healthcare. Remember, in some of these low resource settings, you may only have a CE who can drive digital transformation. You may have a situation like on the left where you have a physician poring over a piece of paper and pen with several hundred patient lines around it or her. Without additional resources, digital transformation or any kind of transformation is difficult. Next slide, please. And finally, we are spending a lot of money on healthcare. 10% of global GDP is spent on healthcare. Most of that is concentrated in high-income countries. But when you look at countries like India, it's a mere 3%. But studies have shown that up to 30% of what we spend on healthcare is wasted. We are doing activities, but they may not necessarily be contributing to better patient outcomes. No other industry would allow this kind of waste. And as we begin to think about digital transformation, we must think about how do we weed waste out of the healthcare system to make it a much more responsive and a responsible healthcare system. Next slide, please. So the way we like to see this, right? A perfect healthcare system is one that does what's best for the patient, family, and the consumer, and the experience they have. Safety, quality, cost, access, these are something we must deliver. And we must think about a new model for workforce development that continues to meet the evolving needs of the patient. But most importantly, we need to build trust with our patients. I was in a conversation and at a lecture recently, and the question of trust came up. And what is the number one thing that leads to a breakdown of trust between a healthcare system and a patient? A patient cannot get an appointment when they need it. How many of you would go back to a restaurant that told you to come back after 3 weeks for an for a meal that you wanted to eat now? I don't think any restaurant that has that kind of a paradigm would exist for too long. So we must build trust with the patient, and the way we do so is focusing on connecting patients, caring for patient, seeing the whole patient, and knowing the patient at the point of care. And this is all predicated on an intricate interplay of digital transformation that includes people, processes, and technology. Next slide, please. A blessing of COVID is that we are beginning to appreciate that our world is different, that we can respond to the challenge of doing more with less, that we must adapt to rapid continuous change. Look what happened during COVID. Telehealth became mainstream within a matter of weeks. We must understand that our patients are different because now they are empowered with technology. They don't need to be trained or coached on how to use technology. They will come in asking to consume healthcare in a different manner. In some ways, healthcare is taking on the elements of consumerism. And we have to be realistic about that we must meet patients where they are. And access to care must be easier and equitable. Next slide, please. So Pull Alliance was created as a consortium of individuals and organizations that see a better future for healthcare. We recognize that digital transformation is hard, is complex. And somebody who is taking care of patients, whether it's a health system or a community hospital or an individual physician or a nurse, is already seeing an increased workload. The demands of patient care are high. Money is tight supply. Supply chains are not working well. But they don't have a strong back-end team that is actually solving for these system-level challenges. When we look at any of the top-performing hospitals, whether it's Mayo Clinic, whether it's AIMS in India, whether it's any other hospital in any other country, there is a back-end team of professionals that guide change, transformation, and day-to-day operations. So Pull Alliance serves to strengthen frontline partners, providing that back end of deeply committed professionals, experienced professionals who can help these organizations with the complexity that goes behind delivering a unit of patient care. Next slide, please. Our framework is built around 5 pillars to advance capacity and capability for the frontline organizations. Knowledge and best practices. If best practices and evidence-based guidelines that are regionally appropriate are applied consistently, we begin to reshape the face of quality and safety in patient care. Workforce development. This is the key. We must look at developing resources locally who can lead and drive change and patient care for the communities where they serve. Digital health and medical technology. And one other thing we make it a point, technology is not one-dimensional. Most people think it's electronic medical record. Technology is far more complex, far more nuanced, and there are a level of expertise in multiple domains that's needed. And we must bring that to bear and not repeat the expensive mistake that some of the developing countries have made. There are better ways to create a connected platform that allows use of technology in a manner that is low cost, efficient, and effective. And fundamentally, change management is hard. It's a science. We simply cannot give somebody in the front lines 5 computers and say, good luck, or a piece of software or a device. They need to be coached, guided, mentored to adopting that change and to performing as a organization that's fundamentally different. A digitally enabled organization is not the same organization that is paper-based. And there's different skill set. There's a different workflow that comes with that. There's different power that comes with that. And creating fundraising opportunities at scale. A lot of these initiatives we're talking about can be capital intensive. And it's imperative upon the global community to create economies of scale where we can say we can bring capacity and capability to the front lines by bringing a collective need to the funding bodies and engaging organizations like GCEA and Pull Alliance to help drive change at the grassroots level. Next slide, please. An example of this is out of India, and we could probably have a 2-hour session on case studies that we have collectively witnessed and been inspired by. The challenges in the Indian public healthcare system echo some of the challenges that many other countries in LMIC have. In India, over 500 million people lack access to health coverage. 30% of rural population travels 5 kilometers or more for healthcare. Approximately 70% of rural primary care is by informal providers. Now, here's an opportunity. Can we bring these informal providers through upskilling into the mix of healthcare delivery that is digitally connected? And 60 million people go into poverty every year due to catastrophic healthcare expenditures in India. And this disproportionately affects people who do not earn a lot of money. The burden of disease is pervasive, and we are seeing in LMICs, chronic diseases are emerging. In India, the rate of cardiovascular disease, 25%. Respiratory diseases, 10%, and so forth. Next slide, please. So what does change look like at grassroots level? This was a pilot that was done by a consortium in India that looked at basic technologies that were brought to an inner city clinic in southern India. Point of care devices, basic diagnostics, a primary care physician, a nurse, a community health worker, and an engineer. Implementing basic technology, providing a model of integrated care to the patient, who you see in the yellow dress, who comes in and is being seen by a primary care physician, is determined that she needs to see a specialist for diabetes. Within a matter of 3 minutes, there's an endocrinologist who is actually consulting with this patient, and she walks out of the clinic with a bag of medicines in 30 minutes, the total encounter. This is happening for somebody who's making less than $200 a month. And this kind of project and paradigm had a net cost of approximately $60,000. When you talk about projects like these that diagnose 1,500 patients who have hypertension who didn't know it, and you prevent long-term sequelae of the disease, but also the cost, the opportunity cost, the QALYs, the DALYs, it is impressive. And I think these kind of models, innovation is needed, and it's repeatable and scalable. And we need everyone on this call and more to be champions of this kind of change. Next slide, please. And I'm going to turn it over to Tom.
Thank you, Dr. Coley. And I know a few people have joined since we began, and try to check out the chat. Let me just review quickly some things as I lead into sort of the clinical engineering aspect of this. We're talking, even though we're using some of the developed world examples, but India, certainly LMIC, we're talking about how do we bring the clinical engineering, the biomedical engineers that serve at the point of care skills in LMICs, notably to make a difference in this digital health transformation. So we're focusing hopefully on and Dr. Coley has shared, and the rest of the presentation here before we come to the panel here in a few minutes, that we're focusing on how can the skills of LMICs be brought to bear on these challenges. And I love the comment earlier of all the health professionals, clinical engineers, biomedical equipment technicians, biomedical engineers, if that's what they're called in your country, need to work alongside the nurses and physicians, and others need to work at the top of our skill set, at the top of our license, the top of our scope of experience. And how we do that, we want to contribute to building trust between patients and healthcare providers. Things certainly got accelerated by COVID, but we're in the business of looking here today, as we are every day, in capacity and capability and competency. And by the way, those of you know that Dr. Coley represents the PUL Alliance, a new NGO in the past couple years that has an MOU, a Memorandum of Understanding, with the Global Clinical Engineering Alliance. And so we work very closely together. So more to say about that. So we all know that there is a growing clinical engineering role, and the clinical engineers as defined by WHO are biomedical engineers who serve at the point of care. And I'll show a little bit, some of you are familiar with these slides, some may not. What does the global clinical engineering community look like? And what's our capacity building framework? And what are some of the stories from our community? So first of all, we can make a difference, and I want to make sure, in those shortages of the other healthcare professionals, nurses, perhaps physicians, others, we can make a difference in many ways. I mean, in the ways you think of immediately, as you talk about clinical engineers and nurses with these digital tools, new skill sets. I mean, one of our traditional skill sets is certainly setting up medical devices in surgery suites, the pumps that are hiding somewhere in the hospital, other surgical devices, laparoscopy and so forth. That's a bit complex. We can set all that up, but we can also work at a higher level with nurses and doctors and others on optimizing clinical workflows. How do you deliver the best care with evidence-based interventions in the best way and the most timely manner? And so stuff we're used to doing and new stuff we need to work on. And I've had the privilege of working with Kaiser Permanente and still have a connection with them through their journal on the kinds of issues that I will bring up. So What happened with healthcare technology and workforce during COVID? Well, we know there was this huge demand for ventilators in 2020 at the World Health Assembly of WHO, where it brings together all of the, 194 member states, ministers of health, and sometimes their prime ministers. And the next year in 2021, there was this huge demand for medical oxygen, both its sources and its delivery tools. And they pointed to our colleague Adriana Velazquez at WHO and said, this is your part of the world. This is your biomedical engineers and clinical engineers that can help us deliver these huge needs during COVID. And as a result, the scope of practice for clinical engineers, biomedical engineers who serve at the point of care through WHO's eyes increased from the traditional medical devices, and now was added protective equipment for COVID, medical oxygen sources and delivery, and digital health tools. Now, we're not the total owners of digital health tools, we know that, but we're a key contributor to how they're used and how they're managed. And so many of you know the year that GCEA was the Global Clinical Engineering Alliance alongside IFMB CED. GCEA was born in 2020, and the first week we were born in October of 2020, we got this contract from WHO to lead an effort of looking at and evaluating health technology innovations for low resource settings. And what Dr. David and I and our team did over the next couple of years is drew from you around the world, 100 colleagues, to help evaluate these emerging health technology innovations. I need to say also that, what's the world we live in? What's happening with medical devices and digital health, and how will that impact workforce? And the truth is, it's just a continuing sharp rise of medical devices and digital health tools. And they need to be optimally managed by yourselves in LMICs and elsewhere. So to assist these challenges, and glad to see that our audience is growing a little bit here. The global clinical engineering community worked hard to develop this capacity building framework for clinical and biomedical engineers. And those of you that are a little bit unclear exactly what clinical engineers do, we manage, as it says on the left, technologies through their life cycle using WHO methodologies. We innovate, as I already was talking about, new models and tools. We ensure on the front end that people get the appropriate health technology selected and implemented, but then we ensure that it sustains during its life cycle. We work through national societies to assist this capacity building effort. And then, once we get through the basics, we need to begin to measure and improve healthcare safety, quality, and outcomes. On the right-hand side, WHO, has measured how many there are of us around the world, and they formally published in 2018 about 800,000 clinical engineering practitioners. That's both engineers, technicians, managers, technologists. But our global community, CE community efforts have shown there's really over 1 million of us around the world in 200 plus countries. Both IFMB CED and GCEA's webinars partnered with WHO during the COVID years were attended by 160 countries. We, as I've already said, helped publish. We were some of the brains behind, the experts behind the Compendia of Innovative Health Technologies for Low Resource Settings. And today, several of you online with me and 30 folks basically on the Strategic Advisory Group for Medical Devices for WHO, and surrounded by all of our WHO colleagues leading change efforts. So what does the framework look like? And I'll be quick here. Is a bucket of knowledge, a bucket of investment, and a bucket of competencies in low, middle, and high resource settings. And of course, in the knowledge bucket, there's a traditional initial education in academics, but training ongoing throughout your career, possibly internships, helpful if you can be credentialed, certified, and registered. But the knowledge bucket today includes digital health and innovation. Investment is all about what is your country doing? Are they bringing in donated equipment, or are they buying themselves? Are they setting up clinical and biomedical engineering departments appropriately staffed and right test equipment and so on? Do they have inventory management like CMMS? But now if they have those things, are they adding value by doing this quality and safety measurement and improvement? And lastly, competencies. That's what we're talking about today when we talk about building capacity and capability and competencies. the CE health technology management activities need to include digital health tools in the traditional ways. And we need to look at, in our competencies, how we work with other healthcare professionals, as Dr. Coley was talking about, how we work through our societies to build up our capacity, how we develop leaders in our countries, and several of you are the leaders and are online. And then we even get to as leaders, we get to the point of developing policy, regulation, and legislation. So I'll bring mine to a close here pretty soon. I can get to my next slide. Quickly, many of you seen the competency priorities from a survey we did in December of 2022 across our profession, across the world. And certainly when it says over there CEIT for the global measurement on the left, that's really digital health tools, clinical engineering, IT, both the electronic health records, but all these digital health tools that were overseen there by Dr. Coley earlier in the presentation. So we have this competency measurement across the world. And by the way, there was nearly 900 inputs. So we feel like we have robust data. Many of you know that the global clinical engineering community, as I've said, is GCEA and CED. And together last November at our 5th Congress in Vizag, India, over 200 presenters from 110 countries representing our world. There is this innovation fellow opportunity that's going on right now as a result of the work in Vizag and at Andhra Pradesh MedTech Zone, AMTZ, there in Southeast India on the beach, as we like to say. And there's 26 fellows at AMTZ that started in July, will be there till December, working on projects. So check out this video when you get the presentation. But this is something you could do next year. And by the way, of those 26 fellows, I think about 20 are from Africa, for example. So there's lots of opportunities in all the regions of the world. Our footprint across the world is large, over 1,100 collaborators that we closely communicate with from over 200 countries. And there are all kinds of people that work with health technology, both ministers of health, physician leaders, engineers, physicists, technologists, technicians, a rising percentage of women. And they're, that's great. And more are coming. To give you a little taste here, working with Kaiser Permanente, besides, traditionally taking a medical device and integrating its output into an electronic health record so that in real time, as doctors and nurses treat patients, they can see the data flowing from several devices, both imaging and vital signs and things like that. Beside that typical medical device integration there in red, number 6, there's several other ways clinical engineers that we proved in Kaiser Permanente in the last 15 years can get involved in this digital transformation. And we can help meet government requirements around electronic health records. The computerized physician order entry that drives alerts in real time during evidence-based care. Social media interfaces before and after and during patient visits. Interactive patient care through testing when the patient comes in right that moment. Patient data from mobile apps for chronic disease management, as was shown in that India case study. Working with wireless infrastructure for workflows and emerging genomic evaluation. How does that fit in, as well as telehealth? So some of you are familiar with the stories that I'll be brief here, but our friends in Pakistan were engaged, who won the right to be recognized by their ministers of health and the WHO reps in their countries, created EHRs, did oxygen surveys across their countries during COVID to improve care at an important time in history. I've already talked about Adriana and what her team did in Geneva and the increased scope of practice. And I've mentioned about Dr. Sharma there at AMTZ in India. And what he created, AMTZ was created before COVID. During COVID, it manufactured thousands of devices, ventilators, oxygen concentrators, and others. And they created millions of test kits for COVID. And he also, Dr. Sharma, has created and published about model for health technology priority setting for policy in his country. So, and I think I don't have as much time at this point to talk about these stories, but in Paraguay, colleague Pedro Galvan in the Ministry of Health helped create an AI screening tool for COVID patients. I already mentioned about Feza in Pakistan and China. Lu Jiamin, she did this study up in the right where, there was digital health transformation for inpatients and communication before and after their hospital visits, all digitally led. Dr. Sharma, when he created all these oxygen concentrators in India, the number 3 there, staged them through 80 warehouses around the country. There were also biomedical engineering service centers, but he leased these oxygen concentrators to the middle class of India for $5 a day and got them there by Uber. Imagine that. Dr. Clark in UK got accurate pulse oximeters for the oxygen measurement at home during COVID in the UK. And we all know that oxygen concentrators are digital pulse oximeters, I'm sorry. If you have them and you have one that's accurate, you can start to tell when your oxygen sat's going down and get early treatment during COVID. And then the Kenya surveillance system. And similarly, in Medellin, our colleagues developed an AI system for sepsis among several universities. In Mexico, our colleague Luis provided CMMS tool, asset management, to the minister to follow all the ventilators that were being developed across that country. Axel, our friend in the US, has been teaching about cybersecurity management. You can see that in the upper side of the slide. Dr. Coley was talking about getting access in hard places around the country. What if you had a digital app that in 15 minutes could get you connected through telehealth to both primary and specialty providers? And that's what Carla and her company Helium are doing. Ricardo, who's on our panel, has created a digital health certification process, and more about that. And Dr. Coley's NGO created remote patient monitoring for patients. So here we are together. This is kind of a handoff to our panel. How can we, clinical engineers, add to our skill sets for education and maybe joint education with nurses? How can we help policy? How can we learn from what we've done recently and share expertise and lessons learned and build capacity through partnerships? So Manish, come on back in and let's hand it off to our panel.
Thanks, Tom. So perhaps what we can do is introduce our panelists and have each one of them give maybe a brief comment about what they've heard or anything else they'd like to add to what we presented. And then we can open the floor up for questions.
And I'll do it there as they're opening screens here. We've got Dr. Ricardo Silva, Dr. Yadin David, I believe it's Dr. Fabiola Martinez, Dr. Elliot Sloan, as well as Calroy and I. So, and these guys are going to speak for themselves as we go here. So how can GCEA and CED and NGOs like Pull Alliance work with you to do this? And, you know, what are some of these skill sets look like as we move forward? So any panelists, take it away.
Okay, if I may.
We hear you. Go ahead.
Okay, thank you. Well, I think, first of all, that the presentations has given us a very deep framework of what is the situation, the current situation, and the challenges we have to face from now to the near future and to the long future. No? I would like to point out in a specific aspect of this challenge that has to do with the workforce. Dr. Manish has spoken and also Tom about the importance of training, no? Mostly on this new framework, in this new paradigm. But I would like to include the basic, let's say the basic training, and by this I mean the academic formation from the students, now that this paradigm is in front of them, and they will face that new digital health paradigm for the professional development. In that regard, I think that we have to include how we can help to the institutions, universities, technological institutions, and every organizations that has to do with the academic formation of our students to include smoothly because I know it is difficult, and I'm a professor, I know what I'm talking about. It's very difficult to make changes in the academic programs because of the structures of the universities, of the structures of the organizations. But we may encourage, no? or professors or college and academia to work on changes on the academic programs, and to include these topics as part of the basement for at least for clinical engineers. And from this, we can have a human resources that had a basement, what we can work with, and we can optimize the resources that Global Alliance and Pool Alliance and all the institutions, including CED, are working on providing our college with high quality information and formation for this new challenge. I think it's very important, and I would like to comment on this. Thank you.
So Fabiola, I hear you. One of the puzzle pieces, and this was in that framework, as you said, was the knowledge base and through the academic setting, and how can we change that? Many of you in the audience are professors, not only the panel, but the audience attending today, over 60 some of us, are professors, and you can help get it injected into your academic settings, and we can help. Other comments?
Yes, this is Elliot. I think it's important to work both with the academic and practicing community to explore, understand, and document how artificial intelligence is pervading these technologies. Anything that uses an app, and in fact, many of the devices themselves have various forms of artificial intelligence, whether it's machine learning or interpretive capabilities. And there's an entire language of life cycle maintenance, an entire process of life cycle maintenance that we really have to work together to describe, to document, to teach. And it's an area that engages our physician, nursing, and allied health professionals, because they too are now operating technologies and relying on technologies that have layers of interpretive tools that change how the product is working. And I think that that's a pretty important area for us to look at very quickly, because it's happening very rapidly.
So both in the academic and the practice setting, these tools are coming, and we in clinical engineers are uniquely positioned to help understand and get best use out of those tools, is some of what I'm hearing from you, Elliot.
That's correct.
Next.
If I may follow up on what Fabiola and Elliot were saying, clinical engineers are in a unique position, or let's say the base, biomedical engineers. We understand health, but we also understand the biophysics, the electricity of the device. And like Elliot said, the devices are now not just devices, they are intelligent computers. They're intelligent devices that add expertise, a layer of expertise on top of the data that they're gathering. But is the data that they're gathering accurate? Are those devices properly calibrated? Are those devices properly interconnected? Is the data flow secure? These are the sort of things that we as clinical engineers need to engage. This is the kind of knowledge that we need to front from the academic side, but also from the corporate and from the experiential side, like we're doing in this webinar. It is up to us to help engage the community in all of those skills and tools that we need to maximize the utilization and the outcomes. Like Manish said, we want to provide better health for all, and we can only do that by using secure, accurate technologies. Thanks.
Great addition, Ricardo. There's a question over in the chat about costs, but first, Dr. David, what's in your mind?
Thank you, Tom. First of all, I want to echo many of the comments in the chat box about the quality of the presentation today. Tom and Manish, great job. good topic, and you clarify a lot of issues. And I want to recognize Manish, that many people don't know as much as they know Tom, about how much you're passionate about redesigning the healthcare system through innovation. This is amazing focus that you have, and this presentation is showing you're passionate. Your past experience as chairman of the board of HIMSS is naturally put you in a great network capacity, and we in Global Clinical Engineering Alliance are proud to have signed an alliance and collaboration agreement with your Pool Alliance Foundation. This is a step in the direction of how can we work together. We published a paper, Tom and I, in the National Academy of Engineering 2 years ago that talks about re-educating healthcare workforce. We are seeing tremendous shortage in clinician workforce, namely physician and more so nurses. And Dr. Colley correctly pointed to the biggest shortage that is coming of about 30 million nurses, if I'm not wrong. You use that statistics. This is an opportunity to re-educate, reallocate skills between clinical engineers, nursing assistant, and physician with this digital transformation. So the webinar usually is focused on education. Today, we are focusing on education and engagement. We would like to encourage everybody online and everybody that will watch the recording later on to get engaged by understanding that you need to re-accommodate your skill tools and increase your idea and information, as Elliot talked about, what is digital health and how can we be more involved with AI, robotics, and telehealth. The dependence of healthcare services, regardless where you are in the world, on technology for delivery of services is at all-time high, and the trend suggests that it will continue to increase, meaning this is a great opportunity for clinical engineers to get involved because technology is our bread and butter. We just need to keep up with our skills, training, and education, and this is one lesson of the presentation today. The second one is that we have an opportunity to help leveling the playing field by being the force that allow adoption of high quality, good safety, and tested apps and application in digital health at the point of care. Clearly, examples are telehealth and robotics at the point of care. We don't see enough clinical engineers involved with that. The next point of where we see an opportunity for us to grow is in away from the brick and mortar, but at home. The new way of delivering care is not anymore just the conventional building, but it can be in small rural area that right now has tremendous delay of care, as Dr. Colley appropriately identified. But we can overbridge and correct that with the proper telehealth tools. And just for example, this week, Apple announced its new smartwatch, I think Series 10, that has apnea detection, major chronic condition that millions and millions of people around the world are losing their health and unfortunately life by not recognizing that. Now you have a personal tool you can wear. It is not regulated yet. It is user commercial device, but we need to find a way how we can integrate both the regulated and off-the-shelf commercial tools that are part of the digital health. It's not one or the other, but it's combination. I like to end with the comment that I learned from the poll question today. 85% of the people online said that regardless AI, we have no or only basic knowledge. That means that by far, your ability to come today and engage in this webinar indicate that you want to be trained. Now it's the job of the instructors, the trainer, the professor, the institution to provide those training. Global Clinical Engineering is committed to develop the program that would help you to reach those training program, just like Fabiola mentioned early on. So I encourage everybody to get engaged, be part of the change by recognizing the potential, understanding that the core value of high quality and safety technology is still our duty, and realize that by putting alliances together, you have an opportunity to have exciting and rewarding career. Thank you.
I think there was a hand up from the audience that I was going to try to enable. And so maybe just one moment. Earlier, there was a question from Hashem Al-Fadel, our friend from Jordan, who serves around the world as a clinical engineer and as a quality consultant and leader, about the cost of these tools and implementing the cost of these tools. I've got a personal quest, you might say, at the moment around some hospitals in one of the countries, well, India, where we had a case study. And we know there's these huge 500 or 1,000 bed hospitals, and they serve not only their immediate community, but they serve hundreds of miles away. So how can digital health tools in a low cost, cost-effective manner serve them as the hub, serve their communities out hundreds of miles cost effectively? And I know Manish and others are wrestling with that question. Maybe a short answer from maybe you and Elliot, Manish.
Yeah. I think cost is a very important thing. And the reality is the amount of money that we have to spend in healthcare is not going to dramatically increase. And I think the first step we must do is begin to look at how do we reduce the 30% waste that exists in healthcare. That's why all of us really need to be thinking about how do we do what we do currently better, more efficiently. And CEs are extremely, extremely vital to that conversation. So like any other business, we must look at how do we actually capture savings that we need to invest in other things. Technology is a driver of cost, but technology done correctly is an investment that allows us to achieve more with less. And what I like to say is, right, we must define the purpose and then work backwards. Data, people, processes, technology. Technology is the last mile, it's the enabler. If we have the right outcome in mind and we know how we measure that outcome, so we know whether we achieve what we wanted to and can continually improve, then we focus on the people, giving them the tools and the skills and the training to adapt to a new normal, to drive that change. Have the people re-engineer the way work is done. You simply cannot take an old broken process and apply technology. All you'll get is a higher rate of making errors. So the processes have to be, this is where what Yadin was saying earlier, that we must reimagine healthcare. This is not about repeating old things, it's creating a new paradigm. And then let's be strategic about technology. Just because technology exists doesn't mean that you have to implement it. Just because somebody is donating a piece of equipment doesn't mean you have to accept it. We must think about how will it be maintained? Are the spare parts available? How do we actually achieve the patient care goals that we have? An example I'll give, right? If we are working at the Women and Children's Hospital and there's an opportunity to get 10 portable ultrasounds that can go in the hands of a community health worker to do prenatal screenings at home, and again, with the right program, not just the technology, versus 2 ultrasounds that go in the hospitals that are end of life cycle, somebody needs to be making a decision, which is a better value proposition, and making a business case for that. So I will say CEs are needed at the table, my final comment, with business planning at leadership levels. How many CEs do we have at the CEO level? We need to be thinking about career tracks there, because we need change agents who are not only driving change at the grassroots level, but at the thought leadership level.
With only a few minutes to go, let's look at the Q&A, and maybe some of the panel can, with us together, can respond. First from Martin, NGO doing work in Ghana. Anybody like to answer that?
Well, I've tried to answer that in the chat box for everybody. Sharing information and collaboration, we really have to innovate in that space, because the information is changing too quickly. We have to have a way of dealing with the concept of think globally, but act locally. The technologies available in one area of Africa are not going to be the same technologies available in an area of Latin America. And the skills and regulatory environments and languages aren't going to be the same. So we don't really have a mechanism to do this in real time. Way back when there were things like wikis that were used for these tools, but we need, if we're going to have such tools, we need to have reasonable management of it, so we have high quality information and so that it's available. I don't have an answer to that, but I think that's something that could be potentially organized with GCEA, IFMBE assistance. And I really think we need to engage our younger and mid-career professionals for whom these kinds of tools are very comfortable and familiar. And it's very, very important, I think, for us to look at this, because books are not the medium that are going to help us address this today, and even peer-reviewed journals have a challenge in terms of who is comfortable, able, and has the resources to write them. That's just my 2 cents.
Thank you. To keep going, let's look at Mladen's question. How can the HTA toolkit be applied to explore and so on? There's somebody else like to take that?
Yeah, I would like to comment a little on this. Well, we have a very strong and very structured methodology to HTA implementation and appropriate solution selection. But now we are facing with new variables. Yeah, we have to include these new variables into the equation, and indeed that led us to reframe the general framework in the HTA. We are working on this by including these aspects, for example, accessibility, availability, affordability, etc., into the methodologies in order to be part of the solution from these steps. And most of the research will be very encouraged from here to the near future. But I think that we first have to replant all the framework in order to include these variables. If you see it as an equation, these variables will even make it more complex, but the complexity, it doesn't mean to be very difficult to implement. We only think of different ways of doing so, but I think it's feasible, and actually I am doing some work on this regard, so that's why I can say that. Thank you.
One of the questions was contact information, and that's being shared on the screen. And when you get this presentation, which you will, there's a little bit of an appendix that I won't explain right now. You'll see it, but some background information of how One Health System is dealing with some of these issues. But so any closing comments or closing questions from the panel, or closing remarks from the panel?
I just want to throw something out there that I want to mention as much as I can. The dream I have is that we can have all of the necessary tools and skills available for everyone at the tip of our fingers. But in order to do that, we need to build a domain-specific large language model for clinical engineering. If we can bring forward our expertise, our skills, our manuals, our documentation, into a single platform so that we can train a large language model on that, then we would have the expertise and the experience available in any language across the world. And that is a dream that I would like to help share with everybody to see if we can make it a reality.
And Ricardo, it seems like the distance from where we are to that is getting smaller for so many reasons. I mean, the right to repair initiatives and many other things like that. Any closing comments, Dr. David?
The large number of questions still in the chat and the Q&A button that you can submit will be answered also by the speakers after the presentation. I like just to thank everybody that took the time and effort to address this large topic, but yet required attention from our field, and to better understand not only what the words are standing for, AI, now they're telling me it stands for Apple Intelligence, but it's also something that clinical engineers need to be part of. I thank you, Tom and Manish, for the great presentation again. Thank for everybody online, and the Global Clinical Engineering Alliance will continue to collaborate and seek alliances with other organizations to make sure that we do have training being in documented books, online, virtual webinars, and other programs. Thank you all.
Thank you. And Manish, just before you make any final words, you heard already there's an MOU, Memorandum of Understanding, between GCEA and Pull Alliance. There's also an MOU with our colleagues from IFMB Clinical Engineering Division. So these are partnerships we're going to build on. There's no time for division among our profession. Manish?
Yeah. Well, thank you, Tom. First of all, I want to just thank Yadin, Tom, and the panelists for the kind words. What an honor it has been to share the panel with you, luminaries in CE space. I think we have a work cut out. I'm really thrilled to see the attendance and the participation. We must now join our arms together and carry the task forward. The work is cut out. Thank you.
Thanks, everybody. We will end now. More to follow. Thank you, panelists.